Welcome to NYU Langone Insights on Psychiatry, a clinician's guide to the latest psychiatric research. I'm Dr. Thea Gallagher. Each episode, I interview a leading psychiatric researcher about how their work is shaping clinical practice. Today, I'm pleased to welcome Dr. Christin Drake, Clinical Associate Professor of Psychiatry here at NYU, as well as the department's Vice Chair of Diversity and Equity. Her areas of expertise include psychiatric care for minoritized people, women's health, and perinatal psychiatry. In our conversation, Dr. Drake talks about promoting equity in psychiatry and improving access to mental health care. She reflects on progress that's been made over the past 4 years, as well as steps, such as better data, for pushing equity forward. Lastly, she talks about the importance of integrating psychiatric care into perinatal health. All right, well, Dr. Drake, thank you so much for being on the Insights on Psychiatry podcast.
Thank you for having me.
Can you talk to us a little bit about the overview of your work and what you're passionate now in your career?
Sure, thank you. I hold the role of Vice Chair for Diversity and Health Equity here in the Department of Psychiatry. And that means I have a sort of broad responsibility for ensuring equitable care and developing programs and initiatives to improve access to equitable, high-quality care across our department, across our departments and our sites. Also a role in providing education on equity, and we focused on racial equity and mental health in particular over the last few years, with the goal of helping to develop structurally humble trainees to add to the psychiatry workforce. And also on the faculty and staff side, working to promote an equitable employment and learning environment here in our department. In my clinical life, I focus on women's mental health and perinatal psychiatry, also psychiatric care of people experiencing sort of extreme social conditions, insecure housing, homelessness, poverty.
I mean, it seems like quite a large undertaking. Where did you begin? And do you still feel like in the beginning stages of this work? Tell us a little bit about maybe kind of where you feel like the field is with regard to this topic as well.
Yeah, I think, I feel this has always been a part of my work. Part of the reason I chose to pursue medicine in a general sense was, for the sort of magnitude of the injustice of poor health and poor access to medicine. So that was always, sort of a motivator in my career. I think as a psychiatrist, I began working like the minute I completed training in various settings and organizations that served people who were experiencing homelessness in New York City. And I think, the first few years after residency are always like a continuation of training and identity formation as a psychiatrist. And so I feel very connected to that work always. It informed my perspective on, our responsibilities as physicians and psychiatrists. So I've kind of been doing this always in various settings. But I think to your question about where we are, I think in 2020, after the murder of George Floyd and sort of more widespread awareness of specifically racial inequities in medicine, we all, sort of across the country, across the globe, began paying more attention to our own sort of local systems. And I think we're very much in the sort of foundation building stage of that work right now, which is in some ways, very challenging to realize, but also very encouraging.
Yeah, and I'm sure it can be overwhelming, but also, starting somewhere and even having a role such like you have, goes to show that there is energy, motivation, money, intention behind this. And speaking of representation, talking about like people of color being chronically underrepresented in departments of psychiatry, for example, only 3.6 of full-time faculty identify as Black. what are the most significant factors that explain this problem?
It's hard to know like the one thing it is, and I think you're right to describe it that way. I think what we're learning is that there are a number of factors. One is the current state. Like 2% of psychiatrists in the country identify as Black, and so it's difficult to imagine as a person considering a career that would be a particularly welcoming space, a particularly encouraging space. The presence of mentors is obviously a challenge for people who are seeking, sort of racial concordance or identity concordance in their mentorships. But, the sort of root cause is obviously rooted in structural issues and structural racism around who has the privilege to be a physician, who can access higher education, who can access medical education. I think that's the largest problem. Once people are here, like once we have a rather diverse group of medical students, I think we can do a pretty good job of, we've had that experience here at NYU. Like the School of Medicine does a wonderful job recruiting a diverse class, and then we can sort of do our thing, and encourage people to consider careers in psychiatry. But it's really the pool of students who are allowed to access this kind of education and who are encouraged to do so.
Yeah, and it seems like there's the larger systemic issues that you're talking about, even just access to education, to medical school. But it sounds like your role now is really connected to the students that are there, and helping them to feel connected and flourishing and growing in their career, because I'm sure it's not just the getting there, it's also the flourishing in the career or feeling, like you said, welcome or safe. And what have you found has been really important in that mentorship role, or that mentorship, like that relationship building? Why is that so important, I guess?
I think it's all relationships. I mean, I'm a psychiatrist, so I think it's all interpersonal. But I think that, for students and for trainees, having someone who can be a support, like a real support, if there's been a really difficult day in the hospital, a really difficult day, in the library, or a test didn't go the way that someone would like having someone to rely upon, someone who's got expertise, who's been there before. I think that helps a lot. And I do think this sort of pathway work, we're doing a lot of this work as well in the department, trying to be more connected in the city to middle school students and high school students. We had a group of high school students here last week who were, just lighting up the place with their questions. They're studying the neuroscience of addiction and are brilliant young people. And so we are definitely trying to sort of put ourselves as a department in front of young people so that they can, know us and imagine themselves here in the space. We have them come here to One Park so that they feel that this is a space they're entitled to. I think all of those subtle things, but they're all very person to person. I think of mentorship like I think of psychotherapy. I think the sort of love and kindness that we offer, as well as our expertise, is the most effective piece.
Yeah, and kind of building, having those building blocks of those relationships seems really important, because there is a psychological impact on a lack of representation, right? And even if you make it, again, to the department, or you make it to med school, if you feel that, underrepresented, that will have an impact on your confidence, how you see yourself, all of that. And so do you find that that's also kind of a place where that relationship building really can bolster confidence and competence and all those things that go together?
Yes, absolutely. I think the trainees, here in our department and in other departments at NYU Langone are often remarking on how important it is for them to see us, those of us senior to them, in leadership positions and thriving and enjoying ourselves and having real say in what's happening. That helps a great deal because, like, otherwise, right, if you sort of look around you and look at the levels above you and you don't see yourself represented, then, that, as you're saying, it sends a message that you can't help but feel unwelcome or like things will be difficult for you as you move forward.
Yeah, and it sounds like nurturing on an individual level, but then doing some of the other work on the systemic level is important. I know that always comes up in these conversations. Where do you feel like there have been, like, what are you really proud of or happy about that you've seen in the wake of the George Floyd murder that you feel like has impacted healthcare systems, and what do you still feel like needs a lot of work?
I think that where I'm most, on this health equity side, where I'm most encouraged is really serious efforts toward collecting the kind of data that we might need to know whether care is being provided in an equitable manner or not. That's what I mean by foundational. Like, we're really, I think, as a country at the beginning of this, like, we've done a lot of documenting disparities, which is very valuable. I'm very encouraged by sort of movement and conversations about moving beyond that now, even a sort of impatience around that now, that we know that there are disparities, and now we need to know how to impact those disparities and be able to track whether our efforts are effective or not. So I think that kind of clarity is like really, really important and really inspiring. The goal is to have health equity related data available to everyone so that, we do health equity focused quality improvement projects now, and it's wonderful. And there are some incredible projects going. I think, we'll be at an even better place when there's not a distinction, between health equity QI and QI, that everyone is thinking about this at all times and has access to the data that they need to track their progress.
And are you looking mostly at faculty and physicians and that experience, or are you also looking at the patient experience?
Both. There's some, yes, both. And there's some work going on in the department around burnout in minoritized providers, but also, there's a connection, of course, to the availability of racially concordant care for patients who want that, who request that, but also looking at, equitable outcomes for patients.
And unfortunately, we have like a robust data to show that there are problems there. And so do you think it's about collecting more data or really focusing on how to change the system?
I think it's going step by step to, try to develop solutions to what we know. So, for example, this sort of most often cited disparities in mental health treatment are, that Black and Latinx and Asian people are much less likely than white people to have treatment for any, a mental illness of any kind. They have a psychiatric diagnosis, they're much less likely to be getting treatment for that. And so there are, I think, local solutions relevant to each of those communities in each of our systems that can be tried and examined.
And kind of getting, like, you're talking almost like a 360 view of the problem and then how to approach it in like a step-by-step fashion.
Yeah, and the nuance is important. I think that's another thing that I am encouraged by, in recent years, that we realize that there's not going to be a single solution for all of the disparities in mental health. So, like, each system and each community and each population, needs its own solution. Our director for the Institute for Excellence in Health Equity, Benga Ogedegbe, is often saying that, like, the solutions are hyper local, and that's why this, like, foundational work around data collection and having useful data is a really smart way to go, I think, and that then leaders of clinical teams can be thinking of solutions that are very relevant to their patient populations.
Yeah, and being in such a data-driven world now, it can't be ignored. So I think that's also really powerful there. And back in 2020, in an article you wrote, you said, it remains unclear how best to approach the removal of racist ideology and accompanying practices among faculty and physicians. Do you still feel this way? And if so, what do you hope to see change?
Yeah, I do think that we feel, I feel a little bit more certain in and a little bit more comfortable in our saying that, the solutions are many and nuanced. I think that's a move toward a move away from, we're not sure how to approach this, and a move away from this sort of like identifying problems and toward identifying solutions. But I do think it's very difficult to know what will change people's practice. That doesn't mean we shouldn't try. So, in our department, we approach things from multiple perspectives. As we said, trying to develop health equity QI that will change norms of practice toward promoting health equity. We also engage in faculty development around equitable practices and obviously trainee education in equitable practices. I think that it is impossible to know in some ways like what will change an individual's mind and practice, and how much of it is head and how much of it is heart. But we can work on all of those fronts, and that's been our approach.
Yeah. And it sounds like at NYU, you feel supported and that there's energy and effort behind this mission. What would you like to see, in maybe other healthcare institutions that, again, would be important to set the stage for this work to begin, if they haven't already?
One thing that we have been lucky to be supported in here at NYU is having senior leaders, vice chair level leaders for diversity and health equity in various departments. So we started in 2020 and 2021 with 5 departments with vice chairs. Ours was one of them, vice chairs for diversity and health equity. And the system is designed to have, a senior leader who will sit on the chair's advisory committees, who will sit on departmental appointment and promotion committees, who have connections to the education teams and have like real influence and power in the departments to be working on these issues at every level. Again, like a recognition that it is sort of important in every corner of the department, and that the people working on it have the authority to change what needs changing and the support to change what needs changing. So I think that system has worked very well here for a number of reasons. One, it's an obvious, I think, show of support from the executive leadership for this work. It shows that it's valued. It shows that it's important. And I think that junior people in our system see that, feel inspired by that, to do their own work, to imagine their own careers with, health equity front and center as opposed to sidelined. And it also creates like incredible energy where we can be collaborating with other departments and sharing our knowledge and sharing our work and be working across our system. Our patients in the system, interact with various departments as they receive their care, as the families receive their care. So I think that's working really well. It also has been wonderful as a collegial community. Another problem, with people doing diversity work or people doing health equity work is high rates of burnout. It's really such a difficult topic. It's been very difficult to move. And I've found, and I know my colleagues who have my position in other departments have found the community of us very, very helpful, like both strategically to amplify the work, share our learnings, but also for us as individuals to stay motivated and to be supported.
Yeah, it sounds like there's a real energy and momentum and excitement, and then also greater chance for collaborators in the health system. I think the worst thing, or not the worst thing, but a bad thing could be if you just kind of create a role and a title, but again, leave these individuals out to get burnout or do the work on their own. But it sounds like you've had the opposite experience where it's felt, yes, there's high rates of burnout because of the overwhelm of the nature of the work, but having collaborators and momentum and energy and support behind the role. It's not just a title that, kind of checks off a box. It's really meaningful work.
Absolutely. Yeah, absolutely. And it came from, the design of this came out of our Office of Diversity Affairs runs a faculty leadership development program. And one of a part of the program is sort of developing a program that might be impactful for the enterprise and pitching it to the executive leadership. And there was a group that pitched this, like the presence of senior vice chair level leaders in DEI, and the institution did it, like that's what we're doing. So I think it's really meaningful as well that it sort of came from mid-career folks who were interested in becoming leaders, saying what they thought they needed to be effective leaders in this space. And it strikes me as one of the things I love about our institution is that, ideas and initiatives come from every level, right? From students to trainees and junior faculty, mid-career faculty, and it's really working. So, and I think a part of the reason it's working is because, it was designed by the people who would be doing the work.
Mm-hmm. Yeah, that's always helpful to, again, have that commitment to the work from the people who want to see it happen and flourish. And it sounds like, again, that is happening, and hopefully more healthcare systems will also follow suit. If I know many have, but like you said, it's been a slow process. Segueing now a little bit, but also we've been talking a lot about faculty physician experience and moving into the patient experience, especially with regard to perinatal health, because I know that's an interest of yours. But I think it's also an area where there has been such a light shown on disparities. That data is just sadly very, I don't know if the word is impressive, but it's just sadly overwhelming. Understanding kind of the data on maternal mortality and mental health. So, and those being both your interests, both perinatal health and mental health. Can you talk a little bit about, what what you think about kind of these issues that people are facing?
Yeah, I think they're very, very connected. The thing that I most want us to be, sort of shouting from the rooftops and alarmed about is the fact that mental health conditions are the number one cause of maternal mortality. That's true in the United States, and that's true in New York City. It's not true in every state, but it's true here in our city. I'm always astounded by the fact that people are surprised by that. That's been true since 2017. We've got another set of data, 2019 data from New York City, that shows that suicides and overdoses are the number one cause of maternal mortality in our city. And so we also have, very innovative work, I think an extension of Arlene Geronimus's work around allostatic load and weathering to make a sort of stronger connection between high rates of maternal mortality among Black birthing people due to cardiovascular conditions, also to experiences of, interpersonal or structural racism and disadvantage. All of it is stress to my mind. And so therefore, all of it is sort of ours as psychiatrists. And I think it's an area in which we can be much more impactful. And there's so much opportunity to be collaborating with our colleagues in obstetrics and in pediatrics, people who are seeing people in the perinatal period during pregnancy and the 1 year after.
Do you feel like there should be, embedded psychiatric care as just kind of a common practice?
Yes, 100%. 100% there should be. We're talking about the gravest outcomes, here, but perinatal mood and anxiety disorders are the most common complication of pregnancy. It's highly treatable, has profound generational impact to treat for parents and for their infants and their children. So yes, I think that to not have access to mental health is to not be providing complete care perinatally.
Yeah, and again, as overwhelming as it sounds, it also sounds like you're pretty hopeful that it's treatable. Are you talking from the point of medication management or psychotherapy? What are the kind of gold standard interventions that you recommend?
Yes, it depends on the problem. But for what is very common, the perinatal mood and anxiety disorders, medications and psychotherapy are very effective. That depends a bit on the point at which a person is able to engage in care, and so the earlier the better. There's an interesting bit of data around pregnant people who are using substances. There are racial disparities in who is able to access medications for opioid use disorder during pregnancy. So Black people, Latinx people are much less likely to access those medications and are more likely to be treated with methadone than buprenorphine. Buprenorphine has a benefit to infants who are born to people who use substances during their pregnancies, in that those babies remain in the hospital for less time, are less likely to need medications to manage neonatal opioid withdrawal syndrome, and are born at higher weight. So it's a significant benefit to the infant to using buprenorphine over methadone. But one bit of, that disparity is often discussed, and it should be discussed. But one bit of that data that I think is really interesting is that people who have a pre-existing diagnosis of depression or anxiety, that disparity is mitigated for them, which I can't help but interpret. We can't be certain what that means, but those people are also more likely to have a mental health professional, on their care team. And so to me, it sort of highlights that, being involved with people who have pre-existing psychiatric concerns, including substance use disorders, being involved in their care through their pregnancies can be helpful to mitigate some of the racial disparities that we see that can have, incredibly important outcomes to those infants. Again, that's a generational impact, and that's why this field is so, I think, for those of us, we're all in this because we want to help, right? We want to be impactful, I think. And so I think being involved in with people in the perinatal period has incredible potential for that.
Yeah. And this issue of the buprenorphine and the methadone, is that just bad medical practice, or it sounds like that's different maybe even than stigma, unless what's happening there if you're saying this is pretty well documented that this can have benefits.
Do you mean why? Why would anyone give a person methadone during their pregnancy?
When there isn't, where there's an alternative, it's not our hands are tied. It seems like there is an alternative with better outcomes.
Yes, some of it might be the challenge of people who have particularly more serious mental illness, and people who are using substances are less likely to have a planned pregnancy than people who don't have those conditions. And so sometimes the situation is one in which a person becomes pregnant and they're already being maintained on methadone, and it can be it's a bit of a challenging decision to decide to switch someone who's already taking methadone if they're stable to buprenorphine. But again, the fact that those disparities are lessened by the involvement of a psychiatrist makes me also wonder about, the support for, people who are working, the mental health teams who are working in a methadone maintenance program might not feel that they have the expertise, with working with people in the perinatal period to make that kind of a switch, or to be thinking proactively. Like, I think proactively, my patients who have opioid use disorder and who might become pregnant, I work on changing them. I work on getting them out of a methadone program and onto buprenorphine in anticipation so that they're well set up. But I think it takes some comfort, which is why, I think educating, there are programs like Project Teach, that's a national program now that seeks to improve provider comfort with prescribing medications, psychiatric medications for pregnant people. I think there's a lot that can be done from an educational perspective to improve the likelihood that people would be on optimized medications. Some of it is, I think some of it is not thinking, we're talking about racial disparities. And so some of it also has to be, what providers imagine for their patients. So if you don't imagine the best outcome, if you're, sort of demoralized by what you're seeing in the communities that you take care of, I think there's a high risk of that too, with provider burnout as well, to not be able to imagine that this pregnant person, should have every advantage in their pregnancy. And so that, I think that's just bad practice.
Yeah. It sounds like, though, one of the aspects you're coming from is hopefully from a population health perspective, with more education, both to the patient and maybe the provider who is integrated with or is working with the patient but might not have the psychiatric training. But it seems like with more education and collaboration and communication, some of these problems could be solved down the road.
Yeah, 100%. And I think we can do that. That's something that we can do as people who have a lot of expertise. I think that can go a long way to just be talking about this as though it's ours. I think that's the thing. I am trying to socialize that the contribution of mental health conditions to maternal mortality is squarely ours as psychiatrists and mental health professionals. And so the more I think we can own that and be communicating about it, the better access patients will have.
Communicating about it, and like you said, hopefully for systems to integrate more psychiatrists into OBGYN care, right?
Yes.
Yeah. Moving on a little bit to, stigma surrounding mental health in the Black community, what role does that play, and what strategies can clinicians use to combat this stigma? Say they are working kind of in private practice or even in, maybe in a clinic. What are some suggestions that you have?
I think that making ourselves known, again, sort of using the human connection, we were talking about this in mentoring, our own Dr. Ayanna Jordan and Dr. Sydney Hankerson has done really interesting work sort of engaging in Black faith-based organizations using religious leaders and church communities to sort of promote awareness and reduce stigma, reduce hesitance around mental health treatment. So I definitely think there's work to show that going to people where they are is helpful. I also think that, to what we were talking about earlier, having a diverse workforce helps, having the ability to offer racially concordant care helps. And I struggle a little bit, to be honest, as a Black psychiatrist, with the idea that stigma, of course there's stigma around mental health conditions. But my experience has also been that whenever we offer like high quality care, people come. I've never been like sitting, and I know you've never been like sitting waiting for people to come. So I think that there's a way in which perhaps stigma and like appropriate mistrust kind of get conflated, and when we can offer like very high quality, structurally and culturally humble services, people come. I worry a little bit that in mental health we are sort of sitting back a little bit, sort of trying to figure out how to make people think different things than they think about us and our services, as opposed to offering the services, being a bit more forward with offering the services. Because my experience is that works.
Yeah. And I think I think, when I was even asking that question about stigma, it's so interesting because it kind of puts the onus on the individual, or it's just the way that it is. Instead, where I think we can look back at a lot of psychiatric research and problems in the past were created by this community. And 100%. So are we a part of the solution as well? Not to be like, oh, well, we created the mistrust, but now there's mistrust. That's a stigma. And I think it's a really good point that you're making of, okay, so since we created the problem, what are we doing to fix it, create greater access and safety and communication, and racially concordant care? And you said like also maybe embedding in communities that are already thought of as safe and a safe space for people as well. And it seems like it might be all of those prongs together that would make the work more meaningful.
Yes, I agree. I think that requires humility on our parts. That's what we're talking about. That it requires like serious self-esteem and serious willingness to sort of own what we've done as a field, even if we as individuals didn't do it, and to be humble. But I found that stance is very effective. That, like, I understand why you wouldn't want to come, and seek mental health treatment. Like, I know the history that I understand your reaction to that history. But I promise you I will try to do better. I think that stance is one that we should encourage, and the people we teach and we supervise and also support, because it's not an easy stance to take. You have to be quite competent and quite strong.
Yeah, and I think it's a stance that needs to be taken by the system and by the individual who is educated about the histories, and understanding, exactly why people could get to a place of mistrust, like you said. But I think takes humility at the large level, like the macro level, and then the micro level. So can you discuss any ongoing or future projects that you're excited about or that might have implications for clinicians?
I'm excited. We're doing a bit of my little team is doing a bit of research in stigmatizing and disrespectful language in the medical literature. I'm very interested in the ways in which we speak about and write about patients and the impact that has on the way that patients are treated. So right now we're doing a review of adherence or non-adherence to the AMA and the American Psychological Association Manual of Style around respectful language in the literature on perinatal mental health in racially minoritized people. The literature, if you type in the words, psychiatric condition, substance use, pregnant, and Black, like the sort of vitriol that comes up on your screen is really astounding. Like lots of disrespectful language, a real paucity of patient-centered language, even in more modern publications. So I am very interested in that, this sort of things that can be going on in the background, like sort of obvious low-hanging fruit that can be changing culture. If students are not seeing disrespect, then perhaps they'll feel more respectful, more hopeful, more humanist as they encounter people who are highly stigmatized in our field. So I'm excited about that work, and there's tons of energy around this. Like, there's very exciting work coming out of Michigan and out of Hopkins around this, like disrespect in the medical record. And so our contribution is disrespect in the literature.
Yeah, and I think with the work you're doing, the theme that keeps coming to mind is it's in the micro, it's in the macro, and coming at it from all sides, step by step, but also large scale interventions as well. So again, I think the work is really inspiring, and I think we're all excited to continue to partner with you and all the people doing this work, and ourselves included. So thank you so much for being on the podcast.
Thank you for having me.
Thanks so much for that conversation, Dr. Drake. If you enjoyed this episode, be sure to rate and subscribe to NYU Langone Insights on Psychiatry on your podcast app. For the Department of Psychiatry at NYU Langone, I'm Dr. Thea Gallagher. See you next time.